Hello, my name is Dr. Amil Agarwal. I'm a cardiopulmonary physiotherapist and I'm going to present a case presentation. Patient was a 47-year-old female housewife from Ghaziabad, known case of COPD with hypertension, hypothyroidism, and type 2 diabetes mellitus, on medication since last 10 years, ex-BD smoker, 40 pack years. Presented to the ER with chief complaint of dyspnea, MMRC grade 4, cough with expectoration and fever since last 5 days. On physical examination, patient was morbidly obese with BMI of 32 kg per meter square. She was drowsy. First and second heart sounds were heard. Heart rate was 55 beats per minute. BP of 80 or 53 mm of Hg. Respiratory wise, chest wall movement was equal on both sides. Respiratory rate of 37 per minute. Bilateral wheeze was present. SpO2 50% on room air. And a ABG was done which showed mixed respiratory and metabolic acidosis with type 2 respiratory failures. HRCT shows bilateral patchy consolidation with peribronchial wall thinning and traction bronchitis. Soon, the patient was shifted to RICU, intubated with NORAD support on volume control mode, FiO2 100%, PEEP of 8, tidal volume of 400, and respiratory rate of 22. Hence, the patient was diagnosed with ARDS with PF ratio of 64. Physiotherapy management during intubation. While the patient was intubated, performed twice daily every day for 25 to 30 minutes, which included oropharyngeal suctioning to remove secretions, passive limb movement to prevent bed sores, proning 10 to 12 hours daily to improve oxygenation, lower limb elevation with DVT jacket to prevent deep vein thrombosis, chest physiotherapy, which included airway clearing technique like vibration and manual hyperinflation. Daily spontaneous breathing trial and recruitment maneuver were performed and the patient was shifted from volume control mode to PRVC on third day and PRVC to pressure support on fifth day and then extubated to HFNC for 4 hours then shifted to NIV support on the same day after stabilization of underlying hemodynamic parameters. Physiotherapy management after extubation twice daily for entire length of hospital stay for 30 to 45 minutes, which included early mobilization, active cycle of breathing techniques, acapella, mechanical insufflation and exsufflation device, inspiratory muscle training, and postural drainage. NIV settings, as it was on ST AVAPs with IPAP of 22, EPAP of 8. Patient shifted outside the RICU on 7 day, shortly discharged, advised to continue PR clinic. Physiotherapy management in PR clinics. It was 6 days. It was performed 6 days per week, once a day for 6 weeks. Each session 30 to 45 minutes. It included aerobic training on static cycle, hand ergometry, and treadmill to improve cardiovascular fitness. It gradually increased intensity by 5 to 10%, and rate of perceived exercise intensity was kept on 2 to 3 on the box scale. Endurance training with therabands and free weights to increase respiratory and peripheral muscle strength. Load was set to 70 to 80% of 1 RM, which included 3 sets of 8 to 12 repetitions, and in between each set there was a rest of 1 to 2 minutes, and also balance and walking. Pulmonary function test after discharge showed mixed ventilative defect with severe obstruction and non-responsive. 6-minute walk test completed. 59% of the patient completed 59% of the predicted distance. SpO2 dropped from 94% on 2 liter to 85. CPET showed peripheral muscle dysfunction with reduced VO2 max and ventilative defect. All the physiotherapy management was done according to the EATS and ERS guideline published in 2013. This is the new paper that recommend virtual reality rehabilitation in patients with COPD. It was a randomized controlled trial performed in Poland in 2020, which included patient uh, uh, two groups. One included endurance exercises and one included endurance exercises with virtual rehabilitation. Virtual rehabilitation was performed on Xbox 360 and Connect Adventure software, which used training of lower and upper body strength, endurance, trunk control, and dynamic balance. And the results suggest that pulmonary program supplemented with VR training is beneficial intervention to improve physical fitness in patients with COPD. This is the rate of perceived scale. 1 shows very light activity, 2 to 3 shows light activity, 4 to 6 shows moderate activity, 7 to 8 shows somewhat difficult activity, 9 shows very difficult activity, and 10 shows maximum effort activity. This is one of the scales. This is known as body mass index, degree of airflow obstruction and dyspnea, and exercise capacity index, or popularly known as BOD index, which includes four parameters and the total score of 0 to 10. And each increase in each point shows severity of the disease. Thank you.